Hello, I'm Glenn Littenberg, Chair of ASGE's Reimbursement Committee, and today I'm going to be sharing with you a video tip on practice management related to what's new in 2019 coming from the CMS final rule, particularly as related to evaluation and management services. I'm going to highlight what I think are the top new things that we should know in our practices, and in other video tips I'm going to go into more detail on some of these and on what we can project possibly happening 2021. First of all, the conversion factor for next year for all physician services hardly changes, goes up a nickel to $36.04. Some of you will receive some positive updates based on your MIP scores, or if you've been participating in advanced alternative payment models, potentially a 5% increase in Medicare fees. But for most of us, it's going to be virtually a 0% update, considering. Now, what good news is that Medicare did not finalize, in other words, not implementing a problem that we thought might occur, which is that they were talking about not paying more than 50% on an E&M outpatient visit if done the same day as a procedure. Fortunately, they decided not to finalize this policy, and we're not sure if they're going to bring that back sometime, but for the moment, this could have been a very serious problem for us in practice and is not going to happen. Another thing they did not do was to apply a standardized allocation of practice expenses against the E&M code services, which would also have disadvantaged GI and reduced the practice expense share of our payments. The other thing they are not doing so far is implementing a blended payment rate for evaluation and management services. There had been talk about taking level 2, 3, 4, and 5, creating a single payment rate for new patients, another single payment rate for established patients, and at least for the moment they've said they're going to defer that until 2021. So what is going to happen is that there is an allowance now by CMS for more simplified documentation to our services. In the proposed rule, there was a lot of discussion about potentially reducing the documentation requirements, and this is an aspect they are going to implement. Now, we're not sure what commercial payers are going to require, and people can certainly still continue to both use the 5 levels of E&M codes in the outpatient setting and utilize the 95 and 97 guidelines in terms of what expected documentation should be in the chart. But CMS is saying that we can potentially now be billing based on time spent during the encounter, even for those visits where counseling and coordination of care isn't the dominant factor of the time. So total time of the face-to-face visit can be used as the basis for billing a code as of 2019. Or the focus can just be on the complexity of the medical decision making, and that can guide your decision about the coding. In other words, the details of the history, the details of the physical exam don't necessarily have to be at the same levels that we were needing them to bill a higher level, level 4, level 5 service, using only the documentation guidelines from 95 and 97. But instead, when we're dealing with more complicated patients, if it's a visit that we're spending a lot of time and doing a lot of counseling, teaching, whatever the purposes of that time, that can be the basis of the coding. And on the other hand, if there's a lot of data you're reviewing, moderate risk or high risk to the kinds of therapies you're talking about doing, or the kinds of procedures you're talking about bringing the patient through, the level of medical decision making may then determine the level of your code, with less emphasis on the history and the physical. Obviously, you document what you need to for medical necessity, and that can still be a lot of documentation. You still need to be doing what you need to do for medical legal purposes to have a complete chart. But we don't have to be thinking quite so much of all the minutiae that are required in the 95 and the 97 guidelines. And the hope is that there is less emphasis on time we spend having to document, potentially more time we're spending actually with the patient, less hassle to the physician, and hopefully less audit risk because we're not focusing so much on these other elements. So For today, this is what we see as new for 2019 in evaluation and management services, and I'll return with more detail on some of these developments and what we foresee for the future. So I hope you found this useful. We appreciate your comments and your interest. Thank you very much.